Welcome to the Dr. Doug Show, your resource for critical updates on women's health, hormones, and health optimization through perimenopause and beyond. Are you worried about cholesterol? Are you confused by the messaging on social media? I know I am. On one hand, you have the traditional medical system, which says that cholesterol is a big problem and that we need to reduce cholesterol at all costs. And then you even have some influencers like Peter Attia in the longevity space saying that you have to bring down cholesterol and that it is the most important thing and we need to do everything we can to bring it down. And then you have people in the keto and carnivore space who would say, don't worry about cholesterol at all. It's not an issue. There's this thing called lean mass hyperresponders and they're fine metabolically, so therefore cholesterol doesn't matter. So what do? I'm in the HealthSpan space. I'm in the anti-aging longevity space. We are recommending for our patients, some of them, to eat carbohydrate-restricted diets. I like carnivore diets, as I've said before in the past, for some people. So what do we do with that? How do we then respond to people that have elevated cholesterol levels? So we're going to get into that. We're going to talk about how we manage this, the protocol that we use, a little bit of the newer research that is supporting potentially a different perspective on this. But let's bring some clarity to this really confusing and pretty controversial area.
3, 2, 1.
Here we go!
All right, so let's just start with some really basic things here. So let's just start with what is cholesterol. So cholesterol is a substance that your body both makes and you can absorb through diet. In fact, cholesterol is something that every cell in your body can make. And it is debatable as to why we even have it in our bloodstream. But either way, our liver makes it. It travels through our bloodstream. It is carried through these things called particles, and I'll do some other definitions here in a second, but it's carried through these things called particles through the bloodstream. It goes to cells, it drops off cholesterol, picks up cholesterol, shuttles it back and forth. Cholesterol is a really important molecule. Cholesterol is the foundation of sex hormones. It's the foundation of elements of our immune system. It is used in every cell, in the cell walls. It is the structure of a lot of our body. So cholesterol is really important, but it is also found in plaque that you find in arteries. So you go back several decades, when we look at heart disease specifically, you could argue other places too, but most specifically heart disease is where this comes to a head. When you look at heart disease and you look at the actual thickening of the walls, the plaque that forms the thickening of the walls that can eventually rupture and cause heart attacks and strokes in the brain, those plaques are made of cholesterol. So cholesterol goes in, it gets trapped, there's an inflammatory response, it creates a plaque, there's all kinds of things that happen in there, but cholesterol is present. So if you go back, like I said, several decades and you recognize that this was the thought process behind why we need to control cholesterol, because cholesterol is there, cholesterol is likely the cause, therefore we should reduce cholesterol. And fast forward now several decades, and we have decades of data that would say that the drugs that reduce cholesterol will reduce events, and particularly secondary events, meaning that if you've had a heart attack, it'll reduce the second heart attack. More so true in men than in women, but nonetheless, it's true. When you look at, again, I mentioned Peter Attia earlier. When you look at thought leaders like Peter Attia and his team, they point out some great research that would show that if we were to eliminate cholesterol in the bloodstream altogether, that you could essentially eliminate heart attacks. That's a bit of a leap, but you could essentially eliminate the development of plaque, and therefore we could eliminate ASCVD or heart attacks as the primary cause of death for adults in the United States and across the world. So that's a pretty big claim. But that's also pretty amazing if it were to be true. But the problem is that we can't really say that because we don't know that that's true. We can assume that that's true. And indeed, with the newer drugs that we have, we are reducing the number of events. We are reducing and potentially even reversing some plaque, but that comes at a significant pharmacological and financial cost. And there are some potential side effects to some of those drugs. So before we get into that, let me just hit a couple of definitions here. So we need to understand what cholesterol is. We already talked about that. when we get a cholesterol panel, you go to your doctor, they order blood, and we get a cholesterol panel, you get total cholesterol, which is all of the cholesterol as is measured in your blood. So most people will break that down into LDL and HDL. This is the simplified version. You'll also hear what's called triglycerides, and then particles, which I've already talked about, which can be measured. Generally, they're going to do that through an advanced lipid profile, which is going to look at the particle number and the particle size. I used to do that test. I don't do that test anymore because it's not easily actionable. So, when do you actually do something based off of those data? It's a little bit confusing and challenging, and there's variation from study to study. So we actually have gone away from measuring particle number, particle size, and now I just use ApoB. And this is what you hear other people in the space talking about because ApoB is a protein that lives on the particles. So we can measure the number of LDL containing particles based off of ApoB. And this is a better predictor of both disease and events than is cholesterol itself. And then we also look at this thing called Lp(a). I won't talk a lot about that here. I'll talk about that later in another podcast. But Lp(a) is a genetic biomarker that looks at the increased risk of developing plaque with a certain amount of ApoB. So this is a kind of a predictor of the development of disease. So those are the players for us. We measure a lot of other stuff too, but those are the primary players that we're looking at on a blood panel. And then this helps us to make decisions around cholesterol and what we need to do for whom and when. All right, so when it comes to treatment of people that have high cholesterol, generally you're going to hear two main things. One is drugs. The other is diet. So before we get into the details of either of those things, let me just talk a little bit about cholesterol and the development of heart disease. I already mentioned that it is present in plaque, which it is. It is thought to be a primary cause of heart disease, which is kind of true. But the role that cholesterol has is not actually really clear. It is associated with disease. It is part of the actual plaque itself, but is it causative of disease? And this is where there's a lot of debate. And again, there are people that would say, drop cholesterol and heart disease goes away. And then other people that say that cholesterol doesn't matter and heart disease can go away as long as you're metabolically well. So what do we do with that? Well, the challenge here is that reducing cholesterol to a minimal or essentially making it go away can only be done pharmacologically. I'll talk about diet in a minute, but we really can only do this through drugs. And there's a lot of resistance to the drugs, particularly the statin-like drugs, because there are potential negatives. People will talk about the muscle aches, the myalgias. My concern is more that when you block the production of cholesterol, you actually end up blocking some other pathways. You deplete the body of magnesium, CoQ10, other things. And so my concern is that from a health optimization perspective, that statins are potentially having more negatives than we know because we don't really have a good way to measure them. People will talk about not having good energy. Is that really related to the drug? It's hard to know. From a HealthSpan perspective, if we can get away from drugs, that's better, but we don't want to do that then at the cost of potentially having a heart attack because we know that that is the most likely cause of death for most people anyway. So one of the ways that I like to look at this is through this idea of is A causative of B? We know that in this case, cholesterol is associated with the event of plaque and heart attack and stroke. But does the cholesterol itself actually cause the thing? And I like this concept of necessary and sufficient. So this idea is great because it helps us to frame whether or not something is an issue or item of concern. Should we actually do something about it, or should we look other places? So we know that if you don't have cholesterol in the body, you won't make plaque. So cholesterol is necessary for plaque development and to have events. So that is true. But is it sufficient? Meaning that do you always develop plaque if you have cholesterol? And the answer is clearly no. Lots of people don't die of heart attacks that have elevated cholesterol. And so we know that it is necessary, but not sufficient, meaning that other things have to be involved to create significant amount of plaque, to have events, to have heart attacks, and to cause death. So what are those things? Well, we consider 4 things as the causative agents of atherosclerosis, ASCVD, whatever you want to call it. Those things are cholesterol, which we're talking about, but those things are also either inflammation, or another way to say that's endothelial dysfunction, so the lining of the arteries that isn't working well, allowing the cholesterol to move in and out inappropriately. High blood pressure is a big deal. So we know that Plaque only forms in arteries. It doesn't form in veins. And we know that pressure is a part of that. So high blood pressure will have an impact on the development of plaque. And then the other one is insulin resistance. And insulin resistance is something we talk about in the metabolic health space. People that are diabetic have high levels of insulin. Assuming they're type 2 diabetic, they have high levels of insulin. They have this thing called insulin resistance. Insulin resistance happens before you develop diabetes and is a part of this whole spectrum of metabolic dysfunction, which I talk about all the time. Insulin resistance will cause endothelial dysfunction. It will cause you to be more likely to develop plaque. That's why people that have diabetes are more likely to have heart attacks, et cetera. So we know that those 4 things are involved in the development of plaque. The question is, what is the significance of each of them? And if we were to say not have any insulin resistance, not have hypertension, and not have inflammation, does cholesterol really matter? And this is where we fast forward to today, where we have people that are on carbohydrate restricted diets, carnivore diets that have increased ApoB or cholesterol. And the question is does that matter? Are those patients at higher risk of developing events, disease, and ultimately dying from a heart attack? And we are learning more information. I'm going to talk about some of this evidence, but this is the challenge that we're faced with today. All right. So I love the space of medicine that I live in. I love helping patients to optimize their health. I'm so privileged to be in a practice where I get to talk about the things that I'm passionate about. It is something that I've really worked hard to create and cultivate, but I'm really, really happy that I'm here and that my team is here because we get to talk about these fun things. For patients, though, this can be a point of frustration because if you go to the traditional medical doctor and you say, my cholesterol's high, they will say, okay, you should change your diet and you should go on a drug. And that hasn't changed for decades. And the dietary recommendations haven't changed for decades. Again, I'm going to talk about that in a second. But most traditional doctors would say you should go on a drug because your cholesterol is high and you're at risk for heart attack and stroke. Okay, fine. But what about the people that have high cholesterol that don't seem to be developing disease? What about the people that have high cholesterol that have cholesterol their whole lives and don't die of heart attacks and have no family history of heart attack? Isn't there something else going on there? And the answer is probably. There's a new term that's been coined. I don't know who coined it, but there's a term that's been coined that is called this lean mass hyperresponder. So I actually happen to be one of these people, so this is personally interesting to me. But a lean mass hyperresponder is somebody who is metabolically well, who doesn't have hypertension, hopefully doesn't have inflammation, but has high cholesterol when they eat the diet that supports the other 3 causes of atherosclerosis. So for me, I eat somewhat carbohydrate restricted, not real carbohydrate restricted with as much as I'm training now, but still compared to most people, I'm carbohydrate restricted. And I eat more dietary fat to get the amount of nutrients and calories that I need. When I do that, my cholesterol goes up. So my total cholesterol lives well north of 200 and my LDL cholesterol is, somewhere in the mid 100s. So not terribly high. Some people have total cholesterols in the, 500s and above and LDL 200 and above. Those are the real lean mass hyperresponders. So I'm sort of up there, but not quite up there. So if I were to take the general recommendations, let's exclude drugs for now and just say, well, what if I were to change my diet or attempt to change my diet to bring down my cholesterol? Because I have, and I can tell you what that looks like for me, but also for my patients that have done this. So the traditional recommendations would be to change your diet. And there are 2 things that you can change. One is to reduce your triglycerides. And the other is to reduce either saturated fat or dietary fat, depending on who you talk to. So let's talk about the saturated fat, dietary fat part first. So if you want to reduce dietary fat and saturated fat, you should eliminate meat for the most part. And I'm not recommending you do this, but this is the recommendation from the traditional medical doctors. Eliminate meat to eliminate saturated fat, eliminate butter, eliminate cream, all these animal sources of fat, because that's where saturated fat comes from for the most part, and coconuts. If you were to do that, you could essentially eat a plant-based diet, right? So you could eat a plant-based diet, you could go vegan, and yes, your ApoB will come down. And it's because your dietary fat's lower, but to do that, you have to get your calories from somewhere. Eventually, you'll have to start eating more and you will eat more carbohydrates because you can only eat so much protein. And that will increase, for a lot of people, insulin resistance, metabolic dysfunction, inflammation, and potentially hypertension. Varies on the person. So then does that make sense to reduce dietary fat, reduce ApoB, but then have a negative impact on 2 other of the 4 factors that go into heart disease? So Potentially, arguably. My preference would be no. So then what about the triglyceride side? So triglycerides, if you're not familiar with triglycerides are measured in the cholesterol panel, but they're not actually cholesterol. Triglycerides are fatty acids that are stacked together, 3 of them, on a glycerol backbone. It's a triglyceride. So 3 fatty acids, glycerol backbone. Your body, your liver specifically, will break down carbohydrate converted into fat, these fatty acids, put them on glycerol, and then you can move it around through the blood that way, or you can actually package it in ApoB containing particles just like cholesterol and move it around that way. Generally, we're going to do that over having free fatty acids in the blood. And so triglyceride is actually a measure of carbohydrate consumption. So then how do we reduce triglyceride in blood? We reduce carbohydrate intake. So then you can eliminate more plants, more starches. You can eat a carnivore diet. You can eat a keto diet. You can increase your dietary fat. You can reduce triglyceride, but then you're going to likely increase dietary fat. So you can see where it's hard to it's hard to pick one style of eating that's going to do both of those things. Some people will respond better to reducing dietary fat. Some people will respond better to reducing carbohydrates. But either way, you're not really going to change ApoB very much. You're not really going to significantly impact your risk from using diet as a tool to change your cholesterol. So really for us, our recommendation is to kind of ignore diet when it comes to cholesterol. The reason why we do that is because I'm more interested in your diet being optimized for the other 3 factors. I want you to not have hypertension. I want you to not have insulin resistance. And I want you to not have inflammation or endothelial dysfunction. And if we can find a diet that fits those 3 things, then we can decide what to do with ApoB and cholesterol. But until then, I don't want to use diet as the tool to change cholesterol. I don't really worry about it from that perspective. I want your diet to improve those other 3 things as well as your energy, your muscle mass, providing adequate nutrients, etc. I don't want you to focus on eliminating protein to bring down your cholesterol. I don't want you to eliminate carbohydrates to bring down your triglycerides to improve your cholesterol. We want to do that from a metabolic health perspective as needed, but there are potentially consequences for some people, and they're going to have reduced performance, reduced ability to work out, to recover, to improve and maintain muscle mass. So I just don't like to use diet to impact cholesterol that way. So now with some newer research that isn't published yet, but there's evidence of some newer research that is supportive of this idea that maybe cholesterol isn't as important as we once thought, and that maybe ApoB isn't the most important of these 4 factors that are predictive of developing plaque and disease. So there's some research that was talked about on some podcast recently. There is a gentleman, Dave Feldman, who's been on podcasts like Carnivore MD, and Sean Baker talks about him. So kind of like the keto carnivore crowd is really interested in this topic because there are so many people in that space that have elevated cholesterol. So there's a physician, his name is Dr. Budoff. Dr. Budoff is currently doing a study looking at these lean mass hyperresponders and the impact of having elevated cholesterol over time. Now, this study is ongoing, but there's some interesting data that's been presented as an abstract, is going to be published likely, that would demonstrate that lean mass hyperresponders that have matched insulin resistance, according to, I believe it's through A1C, BMI, and other metrics to another study group, will have no increased risk over the course of 5 years of developing plaque on very sensitive studies, imaging studies called CCTAs, or coronary CT angiograms. Now, this is really important for me because this is part of what I do and how I manage these things, both for myself and for my patients. So the CCTA is a study that we use that is in addition to what is also called a coronary artery calcium score, or a CAC. People talk a lot about CAC. CAC is an imaging study. These are both CT studies, but CAC is an imaging study that a lot of people will use as a screening tool for plaque, but it's not very sensitive, and there's a high false negative rate, meaning that there are a lot of people that will have a 0 score on a CAC that actually have quite a bit of disease, and it also doesn't look at soft plaque. So we really need to get this very sensitive test called a CCTA. Now, a CCTA is cool because it looks at, like I said, calcified plaque, but also non-calcified plaque, and it is very sensitive to changes in plaque. So we can use this study to follow people that have high cholesterol. Again, I'm doing this for myself and for my patients, where we're letting cholesterol levels ride and looking to see if we develop plaque over time. Because again, I'm more interested in controlling the other factors, blood pressure, inflammation, and insulin resistance, and then we're hoping that cholesterol isn't going to cause plaque over time. But instead of waiting for a heart attack, we're using these sensitive studies to help monitor this over time. So what this new study that was presented at the World Congress on Insulin Resistance, Diabetes, and Cardiovascular Disease recently in LA, this study is showing, again, early findings, and I'm just reading the description, but early findings would show that there's no increased risk. In fact, there was actually a negative correlation of plaque development in people that had high cholesterol when matched for all these other variables. So what does that mean? It means that maybe it doesn't matter, but we don't know that. It means that over the course of 5 years, they didn't show an increase. But we know that ASCVD, heart attack, and plaque development is a disease of decades. Maybe it's just not long enough. We don't know. But I have taken this position of saying, well, for those that aren't interested in being on therapy, particularly for women, which is the majority of our patients, statin therapy hasn't really shown to largely decrease events and disease more so than men, meaning that women don't have the same impact of statin therapy as men. So what do we do with women? Do we put them on a drug that isn't going to be necessarily beneficial? Not unless they have disease. And now we know that we can look for disease through these imaging studies. We can continue to follow evidence like this that was presented by Dr. Budoff and see, is this something that we really need to be watching the way that we currently are watching it? So what is my approach? Well, my approach is to put people on the optimal diet. You can try saturated fat restriction because that doesn't necessarily change your macronutrients. It just changes some of the things that you're eating. Carb restriction is great for some people. And again, I have a lot of patients that are carb restricted because they're metabolically dysfunctional. And we can get their A1C and fasting insulin into a good level with carbohydrate restriction. So I'm totally fine with that. But if that doesn't get your cholesterol where it needs to, and it's not likely to, then that's all we're going to do with diet. Then we're going to follow your cholesterol and decide whether or not you have significant disease based off of imaging studies. We're going to use CAC and likely CCTA, see if you have significant disease. If you do, then we might consider treating your ApoB. We would do that through things like statins, through ezetimibe. There's some supplementations like bergamot that can have an impact, or things like PCSK9 inhibitors, which are going to significantly decrease your cholesterol if you have significant disease, or if you've already had an event. Totally different situation. But if you're on one of these drugs, especially on a statin, we're going to give you the things that you need to support your body in the face of the statin. So you would need like CoQ10 and magnesium and other things, and then be very mindful of symptoms from the drugs because it is pretty darn common to have symptoms for those drugs. So our goal then is that we watch your cholesterol, we treat it if necessary, and you die with that disease rather than from that disease, because we're going to all develop cholesterol in our arteries. We're going to develop plaque, just like all men are going to develop prostate cancer. There are so many things that our bodies will develop over time. It's just part of being alive. It's part of our experience as humans. So our goal is to monitor these things, optimize around cholesterol, and then only treat cholesterol if we need to based off of imaging studies. So I hope that all makes sense. It's a very controversial topic, but our goal is to help to really create a comprehensive plan to optimize health overall, which can be very challenging to do when there's so much noise and so many arguments about specific topics, and cholesterol is certainly one of those. So that's it, my friends. Remember that you are created for greatness, so seek optimal, not average. Don't be afraid to be extraordinary because you are, and that's what it takes. If you haven't already, please check out our HealthSpan Nation. HealthSpan Nation is where people like you can come join other like-minded individuals who are trying to optimize their health for a weekly Zoom topic-driven Q&A with me or a team member, but usually me. We also then house our discount codes for products and services that we talk about on the podcast. We have our private community for people that are in the HealthSpan Nation. And that is where you guys can talk to each other and encourage and ask each other questions in between the Q&As. This has been a really fun community to be a part of. We have several hundred members now that are really helping to elevate each other, and the questions and the topics have been amazing. So if you haven't checked that out, please do that. You can go to drdouglucas.com and look for the HealthSpan Nation stuff there, and you can join from there. And I really appreciate your time. Thank you for making it to the end of this video.
This presentation is for general informational purposes only, does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this presentation are at the user's own risk. The content in this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.